Hello, today we will look at Achilles Tendinopathy or tendon rupture. So we're dealing with the Achilles tendon, and this is the largest tendon in our body. So the largest tendon in our body can be ruptured when you have, for example, athletes who are doing a very competitive sport and they are having a sudden acceleration or deceleration of the body. And also we can see this tendinopathy or this rupture in very sedentary patients. So in people who are not really moving usually, and then suddenly they think they will start to run, and they will run to the bus, for example, very quickly. Usually they are sedentary, so their Achilles tendon is not really developed. The muscles around this tendon is not very developed, and then suddenly we have a high acceleration, and therefore it ruptures. So by very fast running, jumping, and so on, this can then cause a rupture. It is of course important to note that this is not so common. Where we are talking about 1 in every 10,000 patients can get this. And usually, most of them, like more than 80% of these cases, are usually during some sport activity. And the most common cases are in very competitive athletes that are, for example, running. Here we can see a lifetime incidence, so a lifetime risk of tendinopathy as almost as high as 50%. So it's very, very high likelihood that during a lifetime of a competitive runner we will see a tendinopathy or actually a rupture also. The risk of getting this tendinopathy is also increasing when you're running in cold weather. It's also increasing if your leg length are not the same in your left and right side, or if your shoes are very bad, or if you generally have very weak muscles around the Achilles tendon, or if you're having a very bad running technique. The older you get also is a risk factor. If you are male, then it's higher risk. If you're obese, also a higher risk. And we see also that the age of the patient, as we said, the older, the higher risk of getting it. And we are seeing that patients with 30 to 40 years of age are the most common ones. And also, as we said, men are more common than women, and we are actually dealing with almost 4 times more risk when you are men than women. What the reason is, it's another question. If it's because men are doing it more drastically, or they are not so cautious, or if it's more genetic makeup, that's another question. But we see that in men we have 4 times higher risk than in women. Then there can also be risk when, for example, you take a medication called fluoroquinolone. This is an antibiotic, and we have seen that there is an increased risk of Achilles tendinopathy with fluoroquinolone, but we have to look at the statistics, and we have to say that the risk is like almost nothing. Like we're dealing with 1 in 10,000 cases. So this means that you should not really be afraid of Achilles tendinopathy when you take fluoroquinolone, especially if you're taking it in a very, very short time. The risk is very low. But of course, the patient should know the risk that there exists a connection here between fluoroquinolone and Achilles tendinopathy. Let's picture now where this Achilles tendon is. So we are dealing with the lower part of your legs, and we have a soleus muscle and a gastrocnemius muscle. And these 2 muscles will now converge to form the Achilles tendon. And this tendon now will insert, so we will attach to the calcaneus bone. And it will attach on the back of it, so the posterior part of the calcaneus. And when you contract these soleus muscles and gastrocnemius muscle, then the foot will plantar flex, we call it, meaning it's moving downwards, plantar flex. And these two muscles, together with some other muscles called tibialis posterior and peroneus longus and brevis, all these muscles are there to plantar flex your foot. And as we said, this Achilles tendon is attaching to the posterior, so the back of the calcaneus bone. Most of the ruptures will actually be where the blood supply is very poor. And that is around 2 centimeters to around 5 to 6 centimeters above the insertion point of the calcaneus bone. So the tendon where it attaches, around 2 to 6 centimeters above this insertion point. There we will see a tendon rupture. The difference, what we can see in the pain of these patients are, for example, in tendinopathy, that we have a burning sensation. So tendinopathy versus tendon rupture is that in tendinopathy we have a burning sensation, burning pain. And this is getting worse with more activity. And it is much, much better when the patient rests. A rupture, on the other hand, is like being struck by a lightning. And actually some patients will hear a pop sound, so it will be a tearing sound, and this pain is much, much more severe. There are some cases where we can see actually no pain at all, but still it's a rupture. So actually, if the patient is not complaining of pain, this does not mean that the patient did not have a rupture. Actually, one can see in some studies that 1/3 of all patients did not report any pain. So as we see, there is a difference between tendinopathy and tendon rupture. Tendon rupture should or are usually much more severe. It's a tearing sound, a pop sound, whereas in tendinopathy we have a burning sensation. But as we see with all statistics in life, some cases, actually 1/3 of the cases, will come to the doctor's office with not so severe pain. That does not mean that he did not have any rupture. It is important also to differentiate here between ankle pain, so ankle sprains, and tendon pain. In tendon pain, we will usually have pain when the patient is trying to push their foot off from the ground. So they are pushing it with their foot upwards. In ankle pain, we're dealing with pain when the patient is landing their foot on the floor. Then you know it's ankle pain. When you're pushing your foot away from the floor, then it's tendon pain. And this is the motion that we talked about, this dorsal flexion. So flexing down the foot. And that is made with these muscles that we talked about. Soleus and gastrocnemius muscle. And the whole thing is put together in this Achilles tendon. And now comes the big surprise. The patient comes in to the doctor's office and he's able to plantar flex his foot. And this patient now, in this case, is having an Achilles tendon rupture, and he's still able to plantar flex his foot. The doctor, if he's not experienced, will think that the patient did not have any rupture. So the patient, we said 1/3 of the cases will come in with almost no pain. Already there, most of the doctors will think that this is certainly not a Achilles tendon rupture, because that's painful. We have studied that and we know that's painful. No, it's not in all the cases. The second thing that the doctor will think is that the plantar flexion of the foot is not possible with Achilles tendon. And here lies the truth. We said that the Achilles tendon is coming from two muscles, gastrocnemius and soleus muscle. But what about the other ones? The plantaris, the flexor hallucis longus, flexor digitorum longus, tibialis posterior, peroneus longus, peroneus brevis. You see, it's a lot of small muscle groups that are connected somehow to your toes. And this will plantar flex your toes. And in that way, it will plantar flex your foot. So the patient is able to plantar flex his foot, not as good as previously, but he's able to do it. And therefore, this does not mean that he did not have any Achilles tendon rupture. The first thing that the doctor will see is that the patient comes into his office, walking. When you think of Achilles tendon rupture, you think that it's impossible. The patient cannot walk into the doctor's office. He cannot plantar flex, you think, and he has to have really huge pain. And therefore, I'm doing these videos because I want to educate everybody that Achilles tendon rupture can have very confusing symptoms. Or in this case, not so many symptoms. What can we do next as a doctor? We will palpate the foot, meaning we will put our fingers on the Achilles region, and we will ask the patient to plantar flex and dorsiflex. Plantar means downwards, dorsiflex means upwards. And then if we feel now any type of crepitus, we call it, crepitus, that's like cracking feeling. When this motion is done, then we know that it's not really a rupture, but it's rather a tendinopathy, meaning just an inflammation here. But there's no really rupture. Another thing that we can do to rule out something called a retrocalcaneal bursa, that is like a pocket, what we have usually in insertion points of these tendons. And retrocalcaneal, as you hear, retro means behind the calcaneal bone part. So we have behind the calcaneal bone. There we have this pocket, and we call it bursa. And this bursa now can be inflamed. And this is what we call subtendinous bursa. It's below, it's underneath the tendon. There we have subtendinous bursa, and that can be inflamed. And when that is the case, then we don't have any Achilles tendon or tendinopathy. We need to differentiate it. What we do now, we will grasp this Achilles tendon with the fingers of one hand. We grasp it. And then we start to move this tendon side to side, left to right. In bursitis, so this bursa, this pocket inflammation, if that is the case, then it should be no pain when we move this tendon left and right. Because if we do something else, we put the finger of the opposite hand now, and we apply some gentle pressure now deep to the tendon, and we continue to grasp the tendon with the other hand in order to be certain that we are really palpating the bursa with the other hand and not the tendon. And here, if we palpate now some warmth, so really warm, it's tender, very deep down there, then we can think of a retrocalcaneal bursitis or bursitis. So it's very important that we differentiate these, because bursitis is very, very common. Not only there in the Achilles part, but also in the hip regions. And many doctors or many patients think that they have, for example, hip pain, but in fact they have bursitis, meaning a pocket inflammation. And this pocket there is like a pillow for the tendon, because we have a tendon and we have a bone. And in between. We need something soft. And this is like a pocket to not create such a high friction here between the bone and the tendon. A very interesting question always is to ask, what is causing friction or high pressure in the patient's foot? Certainly we have to check the shoes. So shoes of the patients is a very obvious sign. Here we can see, for example, that the inner or the outer edge of the foot is, or the shoe is very used. So we see that, for example, one side of the shoe is very, very used. Then we know that the foot angle is very, very bad. For example, the patient can have a flat foot, then we call it pes planus, or we can have a foot that is having a high arch, and we call it pes cavus, or we can see some heel misalignment. That is when we are dealing with, for example, pronation or supination. Pronation means that the whole angle of the foot is moving inwards. So the whole angle is a pronated inward angle. The pressure is getting on the inside of the foot. When we're dealing with supination, then it's like an outward angle. So it is toward the outside of the foot. And this will create a very bad pressure. The best way is, of course, always to walk in a neutral way, meaning the weight of the whole body is going through the bones in a very, very straight line, not in a pronated or not in a supinated angle. So not inwards or not outwards. Then we also have what we call leg length discrepancy. So left leg, for example, is longer than the right leg, and that will create a very strange walking pattern or strange running pattern. And if you're an athlete, you're doing this every day for many, many hours, for many, many weeks, and you have a small slight leg length discrepancy. We're talking about a couple of millimeters. During the long run, during many, many years of training, this will cause them pain. Then this will cause a high pressure on all your tendons, all your legs. The same goes for all the things that I said before. The flat feet, the high arch, the heel malalignment angle. All these are very important when you are an athlete and you are running. Now, what can we test as a doctor? So we want to do some tests. And this is called the Thompson test. And this is actually a calf squeezing test. So the patient is lying down on his stomach and the feet are hanging off from the examination table. And then we will take our hand and we will actually squeeze the gastrocnemius muscle, this large muscle that we said is connected to the Achilles tendon. And when you squeeze that, then we should see a plantar flexion, which means that the foot should move in a plantar flexion way, that is meaning downwards, but the patient is now lying down, so we will see that the foot is actually rising up. So he is lying down on his stomach, therefore the foot will go upwards when you squeeze the gastrocnemius muscle. And if that is not the case, if we see no movement or very little movement, then we can be pretty sure that this is a rupture. Because as we said, the tendon's purpose is to move the foot in a plantar flexion way. And if you squeeze the muscle, that is the same thing as when the muscle is contracting. The only difference here, mark my words now, the only difference is between asking the patient to plantar flex his foot and doing this Thompson test is that when you ask the patient to plantar flex, he will be able to do it, as we said. We have all these other small muscles that can contract the toes, and therefore it will seem like the patient is plantar flexing his foot. in this case, when we squeeze the gastrocnemius muscle, only the gastrocnemius muscle, then we should see no movement. We didn't squeeze the other small muscles. We only squeezed the big gastrocnemius muscle. And that's the difference. So whenever you, as a doctor, check a patient, always do the Thompson test. After doing the Thompson test, the best way to diagnose tendon rupture is actually to do an ultrasound. An ultrasound can be tricky, so it is not so easy, but if you get used to it and if you get some experience, it is very, very easy. So you just need to take some courses as a doctor and you need to learn this tool. Ultrasound is the quickest, cheapest, and easiest way to assess many diseases. We can now say that ultrasound in good hands is almost as good as an MRI. And an MRI is very expensive, time consuming. You have to wait a couple of weeks or maybe a couple of months in order to get this image. And therefore I always suggest doctors to learn ultrasound. And here in the ultrasound we will be able to see if it's a partial rupture or if it's a complete rupture. If you don't have an experienced ultrasound doctor, then you have to do an MRI. Because CT is not good because you have a lot of radiation. MRI is better than. So MRI is more expensive, but it's better than CT because CT is having radiation. MRI is using magnetic field and that is not dangerous for the patient. What about X-ray? X-ray, the only importance here of the X-ray is actually check the bones. You cannot really see the tissues around the bones. So the tendon, the muscles, and that is actually what we want to see here. So in X-ray, you rather see some bones, and here what is important in tendon, in Achilles tendon here, is that we have something called heel spur. Or we call it Haglund's deformity, or Haglund's deformity. That's a heel spur, that's a bony bump that is on the heel, and that can cause an inflammation. That can cause a bursitis. That can cause this tendinopathy also. So heel spur or Haglund's deformity is the only thing that we want to check in X-ray. MRI is used when we don't have a doctor who can perform an ultrasound, but otherwise, please always do Thompson test, then ultrasound. That's it. So now we have talked a lot about what Achilles tendinopathy is and rupture and so on. We have looked at anatomy, but what about the treatment now? We can divide the treatment into acute tendinopathy and chronic tendinopathy and then tendon rupture. So acute tendinopathy is when it happens. That meaning not a rupture happens, but an inflammation happens of the tendon. Rupture, as we know, that is when the whole thing just ruptures. That's another question. So we will look at acute tendinopathy, and we have to differentiate it between chronic one, because chronic one is when we have more than 3 months of this inflammation of the joint. That's chronic one, and that's the difference between acute and chronic. Acute is within 3 months, chronic is beyond 3 months. What we do in acute tendinopathy is that we will avoid anything that aggravates it, anything that causes it to be worse. And if we feel that, for example, sport, running, of course, these are things that you should not do then. These are aggravating factors. We should also apply ice. So please, when you have a lot of inflammation in this tendon, then please apply ice during the evening when you come home from work or when you are lying in the sofa. Please put some ice, and please do not put the ice too long, just a couple of minutes, 10 minutes maximum, for example. Then we can give 1 week of medications especially from the group of non-steroidal anti-inflammatory medications. Please watch out with these medications if you are having a heart problem, because that's not really a good thing to take. But I would say when you take non-steroidal anti-inflammatory drugs in a very short time, that's usually very fine. The problem comes when you take it for a very long time. Then you can cause kidney problems and heart problems. But if you take it a very short time, let's say 1 week, maximum 2 weeks, and then you can step it down, then it's no problem. And we have different type of non-steroidal anti-inflammatory drugs. Usually what we have seen is that 2 types of these medications help the most. One is diclofenac, and the other is naproxen. Diclofenac and naproxen. This is the molecule's name, and there are many companies surrounding this. For example, there exist combination tablets with, for example, diclofenac and a pantoprazole, which is then a proton pump inhibitor, which will then allow your stomach to not get too damaged. Because as we know, non-steroidal anti-inflammatory drugs can be kind of harsh for the stomach. Therefore, you need to take a proton pump inhibitor that will stabilize the whole thing. Okay? It will not allow this whole stomach to be too acidic and painful. And therefore, diclofenac together with pantoprazole, this is a combination. And there exist many companies. Please look at your country which combination there exists. And the same goes with naproxen. Naproxen, together with esomeprazole, for example, also a proton pump inhibitor. This is also a very good combination. And what we have seen now that in patients with heart disease and patients with chronic problems like kidney disease, heart disease, actually naproxen together with this esomeprazole is better than diclofenac and pantoprazole. Both are really good in causing a reduced pain, but actually I'm moving towards naproxen and esomeprazole because it has lower side effects. But as we said, diclofenac is together with pantoprazole also a very good option, but not for a very long time. So that is acute tendinopathy. And then of course there exists something except medication, and that is called a heel lift. Here we will lift the whole heel around 1 centimeter. So 1.2 centimeters. And we can also do some taping, an elastic bandage. And in this way we will make the whole heel much more stable. And we will also, due to this heel lift, we will make the gastrocnemius muscle and soleus muscle and this whole tendon a little bit relaxed and more relaxed. Because as we know, the whole plantar flexion thing that we have with this tendon and these muscles is actually done by now this heel lift, and then they don't have to work so much. We have relaxed it. So the tension of this tendon is released. And also, as we said, elastic bandage and taping will stabilize the whole joint. So that's acute treatment. There exists now chronic tendinopathy. For example, we said more than 3 months. We will do the same things that we have in acute, ice, non-steroidal anti-inflammatory drugs with naproxen and esomeprazole, this heel lift, and avoiding aggravating factors, but we have to include exercise, physiotherapy, exercise. And we have seen now that the most effective one usually is something called eccentric exercise training. And this is something that you have to do very, very often with a specialized, not doctor, but we will have a therapist, physiotherapist, exercise therapist, and you will stand with your heel now of this affected foot, and you will stand beyond the edge of a step. So you have like the stairs, and then you stand there with your foot beyond the edge, and then you plantar flex it, meaning you move it upwards. And slowly now you will start to lower the heel, bringing the foot back again to normal position. And we can perform now this exercise with a knee that is straight or a knee that is bent 45 degrees. When we do this exercise, so meaning standing with the heel beyond the edge of this step and plantar flexing, that is meaning moving upwards, and then slowly lowering the heel. When you do that with your knee straight, then you're activating that gastrocnemius muscle. When you're doing it with a 45 angle degree, then you're activating the soleus muscle. The important thing now is that when you want to raise the foot back again to the plantar flexed starting position, because that's the starting position, then you have to use the other foot, the one which is not affected. Or you have to use your hands, because that's the whole purpose of eccentric heel drop exercise. We call it eccentric heel drop because we are not focusing on the concentric, you call it, concentric, when you're focusing on the function of what the tendon and the muscles are actually doing. Because as we know, the function of the tendon and muscles is the plantar flexion motion, meaning moving the heel upwards is actually the purpose of this muscle and the tendon. But we don't want to force that. In eccentric heel drop, we rather want to do it, one can say passively, by just slowly lowering the heel, which is actually the opposite of the purpose of it. But we do it slowly, which means that we are not allowing gravitation to just drop the foot, but rather we are using our gastrocnemius and soleus muscle and our tendon to resist this gravitation, and therefore we are going slowly down, and then we will take the other foot and your hands and move the heel up again, and we will once again repeat the slow motion, lowering the heel, bringing the foot back into neutral position, and that's it. We will perform this 15 times, let's say, 15 times. And we will have some break. And we will do this, so that's a set. And we'll do 3 sets of this. And we will do 3 sets of 15 repetition now with the straight knees, which is activating the gastrocnemius muscle. And we'll do it 3 sets with 15 repetitions with bent knees, 45 degrees, which is activating the soleus muscle. We will now perform this twice daily. So that's a lot of repetition. So 3 times 15 is 45 with straight knees and 45 with bent knees, that's 90. And we will do it in the morning and evening, for example. That's 180 eccentric heel drops per day. And we'll do it every day now, every day, for at least 12 weeks, so 3 months. So it's a lot of exercise, but you will see that you will have very, very good results. And of course, if the patient is complaining that he cannot do it, then we need to reduce. We need to reduce the repetitions or the sets. So in the beginning, please be very careful. Go slowly but surely, and then increase it every day. Okay, but that's the aim that we have. Around 180 drops per day, 7 days a week for 3 months. So that was acute and chronic tendinopathy. What about rupture? So patient comes with rupture, then of course it's almost the same. We'd apply ice because of the inflammation to this area every day in the evening. We have to rest, and we have to give non-steroidal anti-inflammatory drugs. When we're dealing with rest here, we have to actually give some crutches. So the patient are not allowed to walk at all. Okay, so we have to have a non-weight bearing of the patient with crutches. Then we have to immobilize the whole ankle. And we will use a short leg splint. Short leg splint. And it's very important that a little bit of plantar flexion is there. As we said with the heel lift, we also had around 1 centimeter of plantar flexion. And the same here with short leg splint. Very important to have a little bit of plantar flexion. So that is the acute initial thing that the doctor do. But of course, the patient will go to the orthopedic unit of the hospital. Why? Because we have to decide now, do we want surgery or not? If no, then do we want a casting or a bracing? These 3 things have to be decided now. The first thing that we did was we just put the patient with a short leg splint. So you see there are a lot of words here. We have a short leg splint acutely, and then the patient goes to the hospital. If the patient is already in the hospital and in the orthopedic unit, we will decide now, do we want to operate or not? If not, do we want to put a casting or a bracing? What is actually an advantage of making an operation? What is the advantage? The main advantage here is that if you are an athlete and you really want to have high pressure once again on your legs, because that's what an athlete wants, then actually most of the doctors, and me included, would say we will do a surgery, no question about it, because the rupture, so the rupture again is very high if you don't do a surgery. So we need to operate this rupture that we have. If we are talking about a regular guy who's not an athlete, then we can say that maybe we can try with casting or we can try with braces. Why? Because the infection risk of an operation is higher than if we just do, for example, a brace. Because there are complications of operations too. And in the long run, if you're not using your leg like an athlete, then there will be no problem. We can use a brace and that's it. Then the question arises, what is better, a brace or a casting? And actually here we can also look at it like this. A casting is very fixed. It's like there's immobilization. The patient cannot move anything there for several weeks. So it's a good protection with immobilization, and that will heal them. The problem is that muscle atrophy can happen. That meaning that the muscles is not used and therefore they are getting thinner and thinner and thinner. So, in which patient is then a casting important? In patients that you know cannot really handle that they have to rest. So very agitated patient that are maybe doing sport and they really want to come back and doing sport again. As we said, athletes will get surgery, I would say. They will get surgery. But there are this group of patients who really are agitated and they want to work again. They want to perform again. And I would say casting is a good option because we will not allow them to use their leg. Because if you allow them too early, then this rupture will really never heal. If you have a very cooperative patient, then I would say a brace. Because brace is something that you can remove. Brace is something that we can now remove and then we can train the muscles and the tendon. Therefore, I would say a brace is the best one because we will not get any muscle atrophy. But it is only best for patients who are compliant, who are resting and slowly but slowly increasing the workload. So that's it, I would say. If you have acute problems, with athletes surgery. If not, decide if the patient will rest or not by talking to them. Then you do a casting for those patients who are agitated, want to go back work again, and then you do braces for all the people who are cooperative. A very important thing to do when you're putting these braces is that we have, as we said, a heel lift. And we need to remove the angle a little bit. So we need to lower the angle every 2 weeks. Why? Because otherwise this heel lift will make a shortening of the tendon if it's there for too long. So every 2 weeks the patient will come to the doctor office and we will reduce this angle until we come to the normal neutral position. Thank you for listening and take care. Have a nice day. Bye-bye.